total hip arthroplasty for bilateral fused hips with stiff spine and a right subtrochanteric fracture. Is that all?
Yes. Thank you, Dr. Dan, and thank you, ROC, for giving me this opportunity. This is a 42-year-old male, works in the government, the stiffness for the past 20 years, on treatment, awaiting THR due to various social, financial, and other issues. He was having increasing stiffness, undergoing some sort of physiotherapy, walking with an aid. He had a history of fall 2 weeks prior to presentation, confined to bed, and this is how he presented to us. Obviously, sitting, standing x-rays was not a possibility. We got it all in the position of where he was. Hips were absolutely stiff, not even a jog of movement, just very painful. Cervical spine is stiff, and the planning involved that's what I'd like to open to the panel before I present what we did. The fracture stabilization, fix first, THA later, single or 2 sittings. What about the anesthesia concerns, and what about the family concerns?
Oh, great, Anil. This is a great case, and it brings up all kinds of interesting, tough questions. I'm afraid the spine surgeons are going to have to sit this one out, but you guys can enjoy watching it. Let's talk to the arthroplasty surgeons. Let's see, Rajesh, do you want to comment on what
we have published this. I would just take down this fusion at the same sitting that I'll do a hip, and we have used an SROM stem because it almost acts like a subtrochanteric osteotomy, and we got good results going on to healing. Never do osteosynthesis on these because there'll be tremendous loads.
Huge loads because the hip can't move, right?
And that will just cut out. So you have to address it at the same sitting.
To be honest, it's kind of a hard osteosynthesis anyway, just because the position is tough, right? Vijay.
And also any kind of osteosynthesis will come in the way of your arthroplasty. Yeah. So, and we know that especially in the subtrochanteric region, when you have a stiff hip above, that is a sure recipe for a non-union as well. So I would just do a hip replacement. I do say either a distal loading stem, SROM would do as well. So that would be...
Vijay wants to do a total hip, but Rajesh wants to do a total hip. We're going to get to the specifics of what you're going to do in the total hip in a minute. Amar, do you want to do a total hip as well?
100%.
Okay, so that was a very clear consensus. Now let's just talk for a second about the dynamics of doing a total hip. Are you going to bring that up, Anil, or do you want me to ask?
Yes, please go ahead. That's exactly what I want.
Okay, so let's see. Rajesh, you wanted to do an SROM, and the idea was that you get fixation proximally, you get fixation distally, you get rotational control, and that would solve your problem of the fracture. Is that correct?
Yes, that's right.
Vijay, you were going to do a fully porous coated implant, or what were you going to do?
Yeah, I'm going to do a Wagner type device. I'm going to have a distal fixation.
Okay.
In a way, this makes your fused hip takedown pretty easy. You know,
what do you think about the fact that the Wagner implant gives good distal fixation, but doesn't give as much fixation of the proximal fragment rotationally? Because it's a fairly small implant proximally.
No, I wouldn't worry about proximal fixation at all. I'm not interested in that. And if it should rotate, a little bit, I'm not worried. As long as I get distal fixation, I'm happy with that.
With a fracture, it may key in anyway, but I admit that. But in general, with the subtrochanteric transverse osteotomies, I'd rather have an implant that gives fixation proximally and distally. Amar?
Yeah, before we get ahead of ourselves and talking about the implants, I promise you this is going to be a hard hip to dislocate.
We're going to talk about that in a second. So I agree with you that we want to talk a little bit about what are the mechanics of what you're going to do, and I presume our speaker is going to talk to us about that.
So basically, that's what the considerations. Stem considerations will come later. It's bilaterally fused. It's bony ankylosed. Yep. That's the thing. The important question is, are we going to do both at the same sitting? Because does it make a difference doing one and waiting for the second one, or that's what I want to open.
Okay, so let's ask the panel that. So some of you wanted to do standard hips in the same sitting. This is a little different because there's an acute fracture. How many of you are going to do it in 2 stages if you do it? 2 stages for Vijay, 2 stages for Amar. Rajesh, you want to do them both at once?
If my anesthetist is happy, I'll do it at 1 stage. This is an emergency. This needs to be addressed. I'll ask him, are you happy for me to go ahead? If he says yes, I'll go ahead and do the other hip.
You would consent the patient for 2, and then you'd go ahead if the anesthesiologist was happy after the first one. You need a cowboy hat. Okay, Amar?
Well, the point that needs to be made is, why is the patient here now? He's here now because he broke his femur.
He's got a fracture.
Right? Yeah. He's got very fused ankylosed hips. They probably don't hurt that bad. When they get that fused, right, they don't hurt that bad, right? So if he can deal with his posture and his vision and all that other stuff, the left hip is not a problem. It's not an urgency. It needs to be delayed,
I think
right? The
that's
right hip
right.
is important, right? So that's
Solve the problem, don't bite off more than you need to chew, right? I think that's a good comment. Okay, press ahead, Anil.
So we discussed that with the family, and they said, look here, they were awaiting a total hip. They would like both done if possible. We told them, explain.
Well, he already had trouble with both hips.
Yes.
Okay,
So
fair enough.
they were told, and they said that if everything's okay, and we said the same thing. We told if the anesthetist is okay with it, and we said we would do it. And that's what we did. We did both at the same sitting because of our experience with, like Vijay said about our subtrochanteric shortening. We used the S-ROM, we used a good sleeve, chorial pinnacle, standard on the other side, did not take too long. Post-op period was not very stormy. We went there. Then we went on to assess the stiffness and the mobility. If you look at it, it's a typical sort of reduced lumbar lordosis, reduced sacral slope, and we can appreciate that spine stiffness in extension. That is a post-op X-rays, calculating all the parameters as well. We went on to do the acetabular version as well. That's what we did. And this was at 4 months. That's at 1 year. And
Hang on, the slides are not advancing.
sorry. I don't know why.
Can we help him advance the slide?
Okay.
There we go.
Okay, sorry. Sorry, I didn't look there. Okay, so that's what we did. Like I said, we made to sit up. Walker, that was the spine assessment post-op. The mobility pattern, like I said, the lumbar lordosis and the spine, the sacral slope was also calculated, reduced, all suggestive of a stiff spine. We did the pelvic tilt and the other parameters. We also assessed the acetabular version, which was around 12 on both sides. This was at 4 months, that is at 1 year, and that's at 1 year again on the spine itself. It was definitely more than a stiff spine, it had that extension, and that is what he was functionally at 1 year. He was doing very well, he's walking, and the typical stiffness or the typical Angst-Pond gait that we see, and that's what we saw. And this is what we've assessed also in our small study of fused hips, and we've seen that it's majority of a stuck sitting pattern. We've published this, and we've calculated all the parameters for these stiff hips, and we've seen that majority are stuck sitting. That's what we've seen in the Angst-Pond. Few are stuck standing, not very common in the Angst-Pond, and that's what we see. So in summary, we need to obviously take spinopelvic parameters, but some situations it might not be possible. Some situations our patients are not able to sit, and that's what we need to remember, I think. The take-home is basically in stuck sitting, reduce a little bit, and stuck standing, we need to pay attention. Both situations, we need to pay attention to the anteversion.
Very good,
Thank you.
Anil. Thank you for a great case. Congratulations. You did a beautiful job with a tough problem. Let's come back to Amar's question, though, because I think that's one that's relevant to the whole audience. Exposure. So what are you doing for the Angst-Pond patients in terms of your femoral neck osteotomy? Are you doing it in situ typically or not? And in the presence of a fracture, how do you get at things and manipulate the leg so that you can do it safely? Did you hear my question, Neil, or were you busy? Okay, anybody else want to take it? Okay, Amar, you want to comment? Go ahead.
Yeah, so I think the first thing you want to recognize with any sort of protrusio, profunda type situation is there a mechanical obstruction to the femoral head? In other words, is the acetabulum capturing the femoral head? Because if it is, you need to remove that obstruction. Otherwise, you're just going to get a fracture in the femur.
Yep.
Right? So that's the key. As long as there's no obstruction, it will eventually dislocate if you do wide enough exposure. But if there is a bony obstruction, you've got to remove it. If it's a posterior wall, a slight osteotomy, or doing an in situ neck cut, all those things must be considered because it won't dislocate if there's a bony obstruction.
Okay, so two, you guys that are doing a lot of them in India, what's your tricks for doing a good in situ neck cut? Because it's very easy to screw that up. It's easy to get the angle wrong. Vijay, you want to take that?
So the structure at risk, the in situ osteotomy, especially in the fused hip, is the lesser trochanter.
Yep.
Your cut should be as away from the lesser trochanter. The great trochanter is never at risk, so it can be close to the great trochanter, but you need to save as much of calcar as possible. And commonly, you'd think that you'll have 2 centimeters of calcar left, but you'll end up with 0.5 centimeters. So that's the structure at risk.
So
and once
stay
you compromise the lesser trochanter, your implant options change quite dramatically. Yeah.
You don't want to have that happen. Yes, go ahead, Anil.
Very, very important point also. Same thing is I would take my neck cut high, but I would also be very watchful of where my saw gives way posteriorly, because it's very easy to go through the posterior wall.
Yes, it's easy to get in the acetabulum. I've seen that happen with short femoral necks before, so you do have to be careful. Rajesh, you're nodding your head. Yes, you've seen that too.
So in this particular case, doing the neck cut is no problem because the hip is fixed. When the hip is fixed, cutting the neck is not a problem. The challenge is preparing the proximal femur after that. So I would typically pass in a reamer from that the trochanteric fragment into the distal femur.
Sure.
Then hold that reamer with the bone hook and do my releases to get adequate mobilization of the femur before I start preparing femur and then the acetabulum, like I said. And again, the key is remain as far lateral as possible superiorly and remain as far medial as possible inferiorly. So inferior cortex, inferior neck is easy to identify. So you see that, keep it under vision, see your distance from lesser trochanter, and then make an oblique osteotomy.
The tenaculum forceps are helpful in manipulating the femur. You can rotate it that way. And the only other thing I would say is that you didn't do it, but I often will put a prophylactic wire or cable around the proximal fragment and the distal fragment, because if you break that proximal fragment in two, school's out.
Lost, yeah.
And I've had that happen once, a long time ago when I was a junior guy. And
Then he'll put a Wagner with the wire around this.
yeah, I've never forgotten that moment. Okay, well, thank you very much for an excellent case. Let's join me, please, in thanking him for a nice job.